Good morning, everybody. First of all, I want to thank Dr. Palumbo to giving me the opportunity to present this talk about intraoperative sonohysterography during hysteroscopy surgery, the concept of digital hysteroscopy. Now, I have no disclosure. The objective of this presentation is to illustrate the benefit of 2D and 3D 4D ultrasound guidance of hysteroscopy and to explain the concept of digital hysteroscopy. Here we see a picture of our operating room integrating 3D ultrasound and hysteroscopy. Now, as you all know, evaluation of the uterine cavity is the crucial step for the diagnosis of infertility patients because a normal uterine anatomy and a normal endometrium are the prerequisites for a good implantation. As you have seen in the previous two talks, 3D sonohysterography is an excellent non-invasive diagnostic procedure that permits to evaluate the uterine cavity and the tubal. Many patients have to plan a hysteroscopy prior to fertility treatment to correct intrauterine pathologies and improve the success rate. Now, what is hysteroscopy? Hysteroscopy is a gynecology endoscopic procedure that allows direct visualization of the cervical canal and the uterine cavity. It is considered the gold standard for the diagnosis and treatment of uterine disease, such as abnormal bleeding, polyps, submucosal fibroids, uterine malformation, and intrauterine adhesion. It can be diagnostic or operative, and it is an outpatient procedure that not required hospitalization. Now, looking back at the history of hysteroscopy, in the past 200 years, this procedure has undergone an extraordinary transformation. We moved to blind procedures like DNC to direct visualization of the cavity. Initially, the instruments have large diameter and the general anesthesia was needed. Progressively, smaller instruments were introduced, allowing the use of the local anesthesia or mild IV sedation. Distending media evolved to CO2 gas that allow only for diagnostic procedures to fluid. And another milestone was the introduction of the saline solution and a bipolar electrocathetery that significantly improved the safety. Finally, in the last few years, the concept of digital hysteroscopy with 3D ultrasound to monitor hysteroscopy has been introduced. Now, thanks to 3D ultrasound, we moved from laparoscopic monitoring of procedures to ultrasound monitoring, making it a less invasive, safer procedures. In this picture, we can see the last hysteroscopy for septal uterus performed in our center under laparoscopic guidance about 20 years ago. In the first image, looking at the fundum, we confirm that this is a septal uterus and not a bicornuate uterus. Now we use a 3D ultrasound to confirm the diagnosis of septal uterus and performing hysteroscopy under 3D ultrasound guidance. As well, we've seen in some clinical cases, we use intraoperative 3D sonohysterography to check the uterine morphology and the uterine fundus, to avoid uterine perforation and to evaluate the progressive and completeness of the resection. Now, we started using this technique in 2004, and we present our first abstract at the RSM meeting in 2010. This is a prospective evaluation of 20 infertility patients undergoing hysteroscopic correction of uterine anomalies. Intraoperatively, a bolus on eye was used to guide the surgery transabdominally. Moreover, a 3D ultrasound transvaginal probe was used to acquire anatomy volume with the hysteroscope in place and monitor the progress of the operation. We conclude that 3D three-dimensional ultrasound, both transabdominal or transvaginal probe, can be used successfully to monitor the progress of the hysteroscopy metroplasty, awaiting the use of the more invasive traditional laparoscopy. And intraoperative 3D sonohysterography is a quick and extremely precise technique. Next, we continue the study at the RSM. And in the RSM in 2013, we present an observational study of 254 patients undergoing hysteroscopy metroplasty under ultrasound guidance, concluding that this technique is a safe and effective procedure and the suction rate of the heart after hysteroscopy metroplastic is high. Now, in 2019, Dr. Guerrero presented a new study at the Usher Congress. This is a retrospective analysis of more thousand patients performed operative hysteroscopy in patients with uterine malformation, submucosal myoma, and intrauterine adhesions. This is the last abstract that presented to the Usher Congress in 2024. This is a retrospective analysis of more than 3,000 operative hysteroscopy performed under 2D and 3D ultrasound. The aim of all this article is illustrating the advantages of performing hysteroscopy under 2D and 3D ultrasound guidance, testing an hypothesis that this technique decreased the complication rates reported into the literature had improved the accuracy and efficiency of the hysteroscopic procedures. Now, the most common complication of operative hysteroscopies is the uterine perforation, and according to the literature, occurs in approximately 1–2% of the cases, and higher during difficult entrances, adhesiolysis, submucosal fibroresection, and uterine perforation. In all more 3,000 cases that we studied, we had no cases of uterine perforation, and we concluded that real-time transabdominal guidance during difficult entrances and resection for intrauterine adhesion, submucosal fibrils, and septa uterus prevents uterine perforation. Now, in the last few years, a few papers have been published highlighting the concept of digital hysteroscopy clinic integrates the ambulatory operative hysteroscopy, high-definition operating room technologies, 3D ultrasound integrated into the tower, into the endoscopic tower, and the concept on the one-stop for only one step to diagnostic and therapeutic approach. Now, how do we do it? We perform hysteroscopy with a slight full bladder and in some cases with anesthetic sedation. We use a transabdominal or transvaginal ultrasound guidance and where is needed, an intraoperative 3D sonohysterography. We use a different type of bolus on machine with transabdominal or 3D transabdominal or transvaginal probe and a compact hysteroscope with an operative channel. And we use hysteroscopic forceps or called scissor, and when needed, a bipolar electrode or mini resectoscope. For the uterine dilatation, we use a continually saline flow with a pressure ranging from 18 to 150 millimeters of mercury. Now, we can an example of transabdominal ultrasound guidance. During the surgery, we are doing a real-time transabdominal ultrasound to guide the hysteroscopy into the cavity. And 3D volume of the uterus is acquired periodically as needed to monitor the progress of the hysteroscopy, and we make several 3D reconstruction of the uterus and pay special attention to the coronal plane because it allows us to a precise delineation of the uterus and determine when the surgery is complete. I will now present some video of different cases. The first is the cases of uterine malformation. This is a case of a complete setta. The ultrasound guidance and especially the 3D ultrasound, we see allow us to control the plane as well as the serosa aspect. In this 3D ultrasound, we can see a complete abscetta and the corresponding hysteroscopy imaging, and finally we see the 3D sonohysterogram reconstruction and the final cavity. This technique permits to performing hysteroscopy in only one step, avoiding uterine perforation. Now, the second case is a second case of uterine malformation. In this case, incomplete subsetta, and in the first three ultrasound imaging, we can see in the first the ultrasound guidance, the directed ultrasound guidance of the scissor in the cavity, and in the last, and in the last two videos, the real time for the guidance during the hysteroscopy, guide the hysteroscope into the cavity. Finally, we can see the normal morphology of uterus at the end and the surgery. This is a 3D acquired at the end and the surgery with TUI and the corresponding rendering. Now move to a cases of submucosal myoma. In the first 3D acquisition, we can check the position of the submucosal myoma, and thanks to T3 ultrasound guidance, we can assess the distance between the fibrous and the serosa, which allow fibril resection without any risk. And in this second 3D acquisition, we can see when the surgery is complete. Now, this is an example of postpartum severe Asherman syndrome after D and C for retrieved placenta. In the first multiplanar reconstruction, we see a cavity completely obliterated, and slowly and careful with ultrasound guidance we resect the intrauterine adhesion. We can see in this video an area with trilaminar endometrium completely separated of the rest parts of the cavity. With ultrasound guidance, we have been able to open this space and obtain a normal shaped uterus. After this hysteroscopy, the patient got pregnant spontaneously. Now, this is another case of uterine adhesions. In the 3D imaging, we can see the correct position of the adhesion, the corresponding hysteroscopic imaging, and at the end, the cavity at the end, the exam, the imaging hysteroscopic and corresponding 3D reconstruction. Now, these are This is a case of retaining product of the conception. In this video, we now have good visualization of the cavity for bleeding, but the ultrasound guidance permit to perform the hysteroscopy safety and permit to remove all part of the lesions. And 3D reconstruction help us to decide when the surgery is complete. Another cases where the ultrasound guidance is important is during the embryoscopy for miscarriage, but I don't show any cases because tomorrow the Dr. Rouleau present the new technique. And sorry for the video. No. Perché questo lo facevo partire con la freccetta, prof, e non so perché. La freccetta. Ecco, okay. Thank you. Sorry for the late video. This is a no good visualization of the cavity for bleeding, but the ultrasound guidance permit to visualization the residual and to remove all parts of this. And at the end we have the normal cavity. Now, after whole type of this hysteroscopy, we put in the uterus or a balloon catheter or anti-adhesion gel adhesion to avoid the formation of adhesions. Now, in this video, we can see an example of the help that ultrasound guidance give during the difficult entrances to avoid creation of false passages and uterine perforation. In this video, we can see the Hagar dilatator enter into the cavity, and after we can see the hysteroscope enter into the cavity. Now, the last example was the cases of cesarean scar defects. In these cases, the ultrasound guidance, and we can see in this video, permit to enter to the hysteroscope into the cavity, avoiding the cesarean scar need and avoiding uterine perforation. Now, at the end of the surgery, in cases of suspect of tubal factor, we check the tube with transvaginal intraoperative 3D sonohysterography, and in these cases we can see the fluid into the abdomen, the fimbria, and the convolute tube, and the corresponding reconstruction 3D rendering. Now, what are the limitations of these procedures? The limitation of this technique is the need to have high-resolution 3D ultrasound devices in the operating room, the need to expert ultrasonographers, and the necessity to have two medical specialists during intervention. And finally, patients with poor quality of image or retroverted uterus is more difficult to transabdominal guidance. In these cases, we use a transvaginal 3D guidance. In summary, what is the take-off message? Ultrasound guidance and intraoperative 3D sonohysterography are an excellent method to monitoring hysteroscopy during difficult entrances, uterine malformation, severe intrauterine adhesion, and submucosal fibro resection. This technique have less complication and avoid the uterine perforation. In the last DTD, the 3D sonohysterography indicates when the surgery procedure is complete, and the use of multiplanar reconstruction permit to perform the procedures in only one step. Thank you.
Thank you very much.